The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey, good morning, everybody. Eric back with you. Today, I want to do a kind of a podcast looking at a few different research studies that I've come across in the last couple of months. I like to do this every so often, and I think it's pretty important, especially for our clinical setting in the pre-hospital environment, to be able to look at this data that's being collected around the world and these studies and how valuable they are, and kind of apply them to what we do every day. Because I definitely think that in the pre-hospital critical care environment, we have to be looking at evidence-based practice. Again, that's the whole point why I started FlightBridgeED, was utilizing or seeing studies and research really not be utilized correctly, and this information not be disseminated down to these rural, small areas, whether you're in a small rural EMS agency or hospital. It just takes years and years and years for this stuff to get down. So again, that was my main focus in wanting to establish the FlightBridgeED podcast. So like I said, we have a few different studies to look at. Podcast won't be terribly long, probably 15, 20 minutes. And before I get started, I just want to, say I'm really, really enjoying this winter weather we're having, or I should say lack of winter weather. I don't know, in the South, if you're living in the Midwest to the, I would say to the East Coast, you're getting a lot of warm weather. We're getting days in the high 60s, low 70s. It's starting to get cold at night, but we're getting that El Nino effect. So I think the West Coast is getting, a lot of the cold weather, a lot of the rain and snow, and kind of getting hammered with the nasty winter weather. But I still kind of consider this a warm fall. I've been outside doing a lot of landscaping and really, really enjoying that. So, like I said, let's jump into the podcast. So the first study I came across, and I talked a little bit about this in the Second Shift podcast. We discussed this in, I believe, episode 13, when we had Dr. Antevi on talking about the hand-Tevi pediatric resuscitation system. And the study was actually brought to my attention by a friend and colleague, Dave Olvera. And he has a mentor physician out of the University of Tucson named John Sackles that just published this abstract. So this isn't the full study at this point. This is just the abstract, but he had released this and at ACEP that was held in Boston at the first of, or I should say like the middle of October. So as we've talked about in other podcasts, everything we do pre-hospitally really does focus around airway management and, starting with passive oxygenation. And we did a podcast about 3 months ago on passive oxygenation. I talked about, the importance of passive oxygenation. I cited the study that was released by Scott Weingart and Rich Levitan looking at passive oxygenation techniques and things like that. And then we discussed the paralytic kind of paradigm. Which paralytic do we start with? Do we start with sucks like we've always done, or do we start with rock? And I think it's fascinating looking at physicians, what they do, what they've always done. And it was interesting when I was talking to Dr. Antevi on the Second Shift podcast, and I had kind of brought this study to his attention, and he said, well, that's really interesting because I've never used succinylcholine in my practice. We always use rocuronium for all of our RSIs. So I found that very, very striking that even in pediatrics, that is the common kind of thread that I've heard that, rocuronium is the standard paralytic, that, just because we've used succinylcholine in the pre-hospital environment for years and years and years, I really don't think that applies now with how we teach airway management, how we apply our techniques, our identifying a difficult airway, and the technology we have now, and the decision-making paradigms, and all the studying and practicing we do and training we do on those procedures. So I found this basically, pretty groundbreaking for me. This is kind of the second study in the last year that has shown that succinylcholine is very substandard in RSI, and it leads to a higher incidence of morbidity and mortality. So for you out there that have the ability to choose your paralytics, and I would say, I know 2 of the major flight companies have that ability. You could choose succinylcholine as your first line paralytic, or you can go rock on your first line paralytic, or you can go vecuronium. So, I think the days are gone where we look at paralytics and say, I'm only going to give succinylcholine because of the short half-life. I want to be able to have the patient wake up. That was the argument years and years ago, and really we don't look at it that way anymore. If you have a failed airway attempt, if you have multiple intubation attempts that have failed, we always go with a backup airway, and we place that backup airway. You're never going to wait for a patient to wake up. And if you look at the other relative or full contraindications of succinylcholine, they go on and on and on. So this study is, again, out of the American College of Emergency Physicians. It was authors John Sackles out of the University of Arizona and some colleagues. I will post this in the show notes for everybody. So remember, the show notes, you're actually going to have to go to the website, www.FlightBridgeED.com. You'll find the podcast, and you'll have all these links to all the articles that I'm going to post after this podcast. So this was a retrospective cohort study conducted in an academic emergency department in the U.S. Adult patients with traumatic brain injury who underwent rapid sequence intubation in the emergency department while using, based on physician decision, rocuronium or succinylcholine between October 2010 and October 2014, so a 4-year period. What they looked at, and they first had to classify patients as how severe are they, and they looked at severity based on what's called an abbreviated injury score, or a head abbreviated injury score, Glasgow Coma Scale. They looked at early occurrence of hypotension or hypoxia, which we know significantly increases morbidity and mortality. They looked at comorbids and any other medications used during intubation, and they classified these patients based on those kind of outliers, or I should say, they classified those based on those indicators. The main outcome of interest was basically in-hospital mortality. Now, it doesn't talk about in-hospital mortality as far as days, but most studies, when they look at in-hospital mortality, they look at 28 days, 28 to 30 days. So after 28 days, did this patient make it or not? From there, basically what we're looking at is the identification of what paralytic they used and the overall morbidity and mortality. And again, this is just the abstract, so I'm excited to be able to read the full study. But it was very, very profound based on the severity score. The severity score, basically, if they had a severity score greater than 4, they were considered a high severity. If they had a severity score less than 4, they were considered a low severity. The final study cohort included 233 adult patients with traumatic brain injury that all underwent rapid sequence intubation. So this is what was very, very profound. In the low severity category, there was really no difference in morbidity and mortality. Really, there was about a 1% difference in favor of rocuronium as the paralytic. So it had a higher incidence of morbidity and mortality just by 1% by using succinylcholine. But when you look at a patient that has a high severity, so again, remember that high severity score greater than 4, there was a 22% increase in morbidity and mortality over succinylcholine. So in patients who were given rocuronium, mortality was 22%. in the high severity setting. In patients that were given succinylcholine, there was a mortality rate of 44%. Now, if you've read a lot of studies, I'm sure you know and understand that that is a massive, massive difference in morbidity and mortality. A lot of studies, man, if you get 2, 3, 4% difference in showing that one medication or one procedure is beneficial to another, that's pretty profound. Or if you see a study that shows, a 7% reduction in mortality by using this medication, that's profound. So this is 22%. That is a huge, huge number to me, in favor of using rocuronium over succinylcholine. If we couple this with what we know in the article that we talked about in the Passive Oxygenation podcast, where I posted the article that Scott Weingart and Rich Levitan had done, and we look at the incidence of desaturation with succinylcholine versus rocuronium, and you can refer back to that. I will post this article along with the Scott Weingart, Rich Levitan passive oxygenation article in the show notes of this podcast, and you can look at it and compare it. But if you remember, or if you haven't listened to that podcast, I highly encourage you to do so. There was a 2-minute difference in desaturation while using rocuronium versus succinylcholine. So what that means is that patients that were given succinylcholine desaturated 2 minutes quicker than patients that were given rocuronium. And if you think about the types of patients that we RSI, in this study, traumatic brain injury patients, we know that you have a potential 50% increase in mortality if they have any periods of hypoxia, and we have another 50% if you have any periods of hypotension. Well, a lot of times hypotension, hemodynamic instability is secondary to oxygenation deficits and things like that. Obviously, you could have massive hemorrhage and things like that, but a lot of times they go hand in hand. If you correct the oxygenation, you maintain a good oxygenation, a lot of times your hemodynamic stability is much better. So now we have 2 studies that are showing that rocuronium is far better as far as overall morbidity and mortality, secondary issues. And, for me, this is groundbreaking. For me, I have the ability in my clinical practice, in my primary job, to choose which paralytic to go with. And I'll tell you that I will always go rocuronium first, and I'm probably not going to be using succinylcholine anymore because of the advances in our ability to maintain an airway, to assess an airway using the different criteria for difficult airway, the ability to use video laryngoscope technology, and this new crossover technique that's being taught. So again, rocuronium is going to be my go-to paralytic. So what I want you guys to do out there is I want you to read this article. I want you to read the Scott Weingart, Rich Levitan study, and I want you to kind of make your own judgment and opinion and start changing the way you practice. Don't do it. Don't use succinylcholine because we've always done that. We have much better training, understanding of airway, understanding of pharmacology than we did before, and there's really no need to use that. If you also kind of consider, there's an article that was put out a while back, and it's called Incidence of Duration of Continuously Measured Oxygen Desaturation During Emergency Department Intubation. The conclusion, and again, I'm not going to go through this entire thing, the conclusion of this is that 1 in 3 patients undergoing ED rapid sequence intubation experience oxygenation desaturation for a medium duration of 80 seconds. That's a long time. Pre-intubation saturation is less than 93%. Multiple intubation attempts and prolonged intubation times are independently associated with oxygen desaturation. So again, this study kind of tells me that we need to completely change the way we deal with pre-oxygenation. And days are gone that we are actually going to bag our patients. Remember, the whole passive oxygenation technique, apneic oxygenation, is done and it works. I'm telling you, it works. I've used it many, many times in the last few months, and I'm just blown away with the ability to maintain a patient's O2 sats greater than 95, 96% with very little effort. And so remember, you place a nasal cannula on the patient at 15 liters per minute. Always just go 15 liters per minute. Put that on the oxygen source, grab a non-rebreather, put the non-rebreather on the patient at 15 liters per minute on a second oxygen source. The reason why I kind of advocate doing that over a BVM is I think that, we're all human. We've all been taught to use BVMs to bag our patients. And I think if you just place a BVM over the patient's mouth and you let that blow in similarly to a non-rebreather, I think it's really easy for us to want to bag our patients. And we don't want to do that. There's no reason to do that. Graham's law of diffusion, of going from a higher concentration to a lower concentration, is going to allow for excellent oxygenation. And so again, I've used this many, many times, and it's all about that pre-intubation saturation of less than 93%. We always want to maintain that 93% minimum before we ever start the RSI procedure. So get that oxygenation up, take the time to do that. It really will make a huge difference. And if you couple that with patients that have traumatic brain injury, multisystems trauma, you're really going to be better off in the long run. Again, I will post this article. I'll post the article on Scott Weingart and Richard Levitan regarding the desaturation and the passive oxygenation. And I will post this article on succinylcholine by John Sackles as well. All right, so let's move on. Another thing that I wanted to talk about is, the whole ketamine thing. And we've done 2 podcasts on ketamine, and the podcasts have done very, very well, but I still think there's a very poor understanding, and I think people are scared to death of ketamine. I think there's a lot of misnomers out there, just from people not understanding it, not knowing truly what it does, and they're myths. They're myths, just like we've seen myths for years and years and years on Levophed, leave them dead. And it's taken years of published data, published studies to get people to change and move away from dopamine and start using Levophed. Well, this is no different. I can tell you from my experience of using ketamine, I've been very, very excited about it. It's worked really well. It's taken patients that were tough to manage, that were tough to keep sedated or deal with their pain. It's made that much easier for me to manage them. So this study came out in, Trauma Resuscitation Emergency Medicine. It's called Ketamine for Pre-Hospital Trauma Analgesia in a Low-Resource Rural Trauma System. It's a retrospective comparative study of ketamine, opioid analgesia in a 10-year look in Iraq. So this is a Iraq military study, which is pretty cool. And when we look at ketamine, again, we can use ketamine for multiple reasons. And again, I encourage you, if you haven't listened to those podcasts, go back to the ketamine podcast where we do the debunking myths with Dr. Mike Abernathy. And then I did a podcast previous to that, just looking at ketamine in general. So when we look at ketamine, again, we can look at ketamine and we can give it for our induction agent prior to RSI, prior to our paralytic, which again, I'm a very big advocate of. Again, I'm not using etomidate. I'm going to go ketamine for that. There's really no reason for me to use etomidate unless I have a blood pressure that's very, very high. If I have a, maybe an aneurysm or some type of a hypertensive head bleed, something like that, where I don't want to see that transient increase in blood pressure or heart rate, then I might go etomidate in that setting. But for most patients that we deal with, ketamine is going to be a great choice for that induction agent. So what they looked at a whole bunch of patients, and they looked at patients in the pre-hospital environment, obviously, that have blast injuries, penetrating trauma, blunt force trauma. They were classified based on 3 different kind of levels. They gave pre-hospital analgesia for trauma victims. So they would start off with a medication called pentazocine. They would give a dose based on, their protocol there. And then they would give secondary doses of ketamine. So they would give a dose of 0.2 milligrams per kilogram. So very, very small dose. Again, remember, we can use ketamine for different reasons: induction, pain, sedation, and obviously excited delirium. So 0.2 milligrams per kilogram, very small doses. But what they found was they'd give the pentazocine, they'd give ketamine, and then there was patients that they decided based on hemodynamic instability. Again, this was paramedic choice, so there was no strict guidelines of when or when not to do this. So they were able to look at 3 different subsets: patients that got just that narcotic, patients that got the narcotic and ketamine, or patients that didn't get any analgesic medication as well. And they looked at a severity score, and that severity score really told a lot. So in conclusion, the pre-hospital anesthesia of trauma victims improved physiologic severity indicators in a low-resource trauma system compared to the narcotic that they were using. Why did that happen? Well, if you think about the effects of ketamine, and again, I'm not going to go into an in-depth pathophysiology of ketamine. I've already done that in other podcasts, so if you don't understand that, please go back to those podcasts and kind of review. But remember, it's got excellent effects on the central nervous system. It improves blood pressure, can bump up your blood pressure by 20 to 40 millimeters of mercury, will improve and increase heart rate. It is cerebral protective, so remember, it's cerebral protective. It actually improves blood flow to the brain. All those myths that you hear about using ketamine in patients with traumatic brain injury or, head trauma, things like that, and that it's going to increase ICP is absolutely false. Again, it's absolutely false. Multiple studies have shown that that is absolutely false. And again, I believe Mike Abernathy in the podcast where we debunked the myths, he quoted why that initial myth was established. It was established based on an old study, and there's no merit to it. So again, don't be afraid to use ketamine in that setting. But what they found is when they used ketamine, the patients actually did better. The more severe patients in this study got ketamine, and those more severe patients actually improved as far as their hemodynamic instability. So their airway was improved, their blood pressure was improved, their heart rate was improved, and they were able to get these patients to a surgeon and to where they could perform these procedures, life-saving procedures, operations. So again, I'll put this in the show notes. One thing interesting that they did is every time that they gave ketamine for a second dose, so they would give that initial narcotic, they would give ketamine, but then if they gave a secondary dose of ketamine, they always followed that with 1 milligram of atropine. We talked about that in the previous podcast as well, is the incidence of salivation. And it happens actually quite a bit. It's not an uncommon thing. So they would automatically just always give a milligram of atropine for these patients, and they would also give some type of benzodiazepine with these patients as well in this setting, just so they didn't have any issues with that reemergence phenomenon. Pretty profound to me, again, that ketamine is a very stable medication, really does improve hemodynamic instability and kind of buys you that time. And I've actually experienced that myself on a few really severe trauma patients where I have felt that it has really benefited not only the patient, but me as a provider and my partner during the flight. So in the end, ketamine seems to be a great choice for pre-hospital anesthesia in trauma victims, particularly in those severe classifications. Now, one of the things that I do want to talk about, and I'm going to add this to the show notes as well, and I'm going to put a YouTube video in the show notes, is I've had people come to me. One of them is Evan, and I talk about Evan quite a bit. As far as our IT systems administrator, our developer, he does a lot of stuff for us that he doesn't get credit for. So I want to say thank you again. But he's also a flight paramedic, and he's a very, very good, outstanding clinician. And he's had 2 different incidents where he's pushed ketamine, and they've had laryngeal spasms. And if you remember back to the podcast with Mike Abernathy, he's talked about 2 incidents as well. And all 4 of those incidents, I've talked to Mike Abernathy about it, I've talked to Evan about it, was that they pushed the medication a little too fast. We all do that. It happens all the time. So one of the things you have to remember is if you're going to give ketamine, and this is adults or pediatrics, you want to make sure you're pushing this over at least a minute and a half. Don't be pushing this over 20 seconds because you could possibly have that. But this is very easily managed. I don't want you to panic if this happens. There's a maneuver called Larson's maneuver. And Larson's maneuver is a procedure that you can do if you identify that your patient has laryngeal spasm secondary to ketamine being pushed too quickly. And essentially what you're going to do is you're going to place your patient, obviously your patient's probably already supine. You're going to find the little notch that's underneath the earlobes. And that is basically this little notch, and you're going to put your middle finger in that little notch. And this is anterior to the mastoid process of the temporal bone. So you place your middle fingers in those notches right underneath the earlobes. You'll try to feel it on yourself. It's kind of a pressure point area, and you should kind of feel a little bit of pain if you push it on that. You're going to place your middle fingers in those notches. You're going to put pressure on those notches, and then you're going to reach up with your fingers and your thumb, and you're going to open the jaw if you don't already have the patient intubated. If you have the patient intubated, you can still do this, but it's basically, if this happens when you initially push ketamine, your patient's probably not going to be intubated in that context, so you want to open their airway up. So place those middle fingers in that notch, lift the jaw up with a modified jaw thrust, and it should relieve those laryngeal spasms, and then just manage our airway with a BVM until it relieves. Again, I will put a demonstration video of Larson's maneuver in the show notes. I highly encourage you to look at this and practice this in case this happens to you, and you should be good to go. So that's all I have for this podcast. It's I think a very warranted podcast looking at some, big deals in medicine as far as research goes with ketamine, with succinylcholine versus rock, and passive oxygenation and techniques we can do to improve, incidence of hypoxia and desaturation in our patients with RSI. As always, I want to thank everybody for the following, for all the great emails, for all the kind words. If you haven't picked up your ventilator management or pre-hospital perspective book, please do so. You can always come to the website or go to Amazon.com. I really, really encourage you. I sent letters out. If you've read the book, you like the book, if you could go onto Amazon and do a review, I would really, really appreciate that. It would be very, very great. Obviously, the podcast went a little longer than 15 minutes. I think I do that all the time, but hopefully you've enjoyed the podcast. If you have any podcast ideas or any case presentations you want me to present, don't hesitate to email me. And as always, if you have any questions, please email or call or text, and I will attempt to answer those questions. So on behalf of everybody at FlightBridgeED, I just want to say thank you, and I hope everybody's having a great winter and upcoming holidays, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.